I'm going to move on now to Professor Fiona McNicholas, if that's okay, in the interest of time. Fiona, you're our last presenter before coffee break. To give a little bit of background on Fiona, you're a consultant child and adolescent psychiatrist working in Paediatric Liaison Psychiatry in Children's Health Ireland, and I think in the Lucena Clinic as well. You are the recipient of a number of grants and you've published widely, mainly in the area of self-harm, suicide, stigma, the mental health care needs of families and providers, especially during COVID-19. Your current work involves in professional working with children, both clinically and in other research methodologies, including action research to gather evidence to support best practice. And we're delighted to welcome you here today to talk about the child and adolescent mental health service before the perfect storm, the calm before the perfect storm, which was a picture of concern pre-pandemic. So thank you and welcome, Professor Fiona McNicholas.
Thank you, Claire, and welcome everybody, and thanks for organising this very important symposium. I'm going to share my screen if I can. First thing I think I was going to talk about was saying what is stress. It's something I'm experiencing at the moment while Justin is trying to get the slides up and why I didn't check for the mouse. But it really is when the demands placed on us are greater than our perceived ability to cope. And what we normally do is we try and reduce those demands or manage them. And then we start kicking in our adaptive, hopefully, coping responses. But of course, sometimes that leads to maladaptive coping. I was going to present you the stress vulnerability model. I haven't got a printout of my slides, so it's hard for me to do that. So this is the stress vulnerability model, and it just shows us how every day we all experience the stresses, and for the most part, we cope with them. They're generally transient, and most of them, fortunately, don't go above our resilience threshold. However, if you have a number of them together, or if they're very particularly salient for you, they might do so, and that causes us a significant amount of stress. Next slide. There are some people that have individual vulnerability, those that might have anxiety, and therefore their resilience threshold is much closer to the ambient stresses that they experience. And something as minor for me, perhaps, as what clothes I'm going to wear when I go out, or whether I'll give a talk in public, may be extremely stress-provoking to others and cause them significant impairment. And obviously, cumulatively, the number of stresses we have starts to deplete our capacity to cope. Next slide. There was one slide missing there. Jason, I suspect, well, don't worry. The only slide there was to say that I'm going to come back to the idea of COVID, because that has acted as a prolonged continuous stress for the last 12 months. So work or stress happening in the workplace is referred to as occupational stress, and it's part of the ICD diagnosis. And not because it's a disease in itself, but it does lead on to and impacts on our health status. Christine Maslach is the grandmother of occupational stress, and she has spoken very elegantly about burnout and 3 salient features which allow us to recognize when somebody has gone well above our resilience threshold and is now working and experiencing burnout. 3 features are emotional exhaustion and physical exhaustion, ineffectiveness or a sense of incompetence in one's ability to do one's work, and cynicism, where they lose the interest, they couldn't care less, they're clocking in, clocking out, and really not putting effort and enjoying their work. She talks about a mismatch between the person and the job, and there are 6 domains that she considers: the workload, typically when it's excess, whether the person has the ability to control the sort of work that they do, whether they perceive that the reward, whether it's monetary or not, is adequate for their job, the community or the group of people that they work with and how aligned are they, and whether they enjoy their company and whether that in itself is not stressful. Obviously, an employer must feel that there's fairness and justice in their work, and also that their organization, the values of the organizations align with their own. And this might have been something that Neil Greenberg was touching on moral conflict or moral injury. at times when we have to discharge somebody because somebody else needs that bed, and we're aware that actually they should be there much longer. This is something that causes a conflict with our own values. Next slide, Justin. So we know before COVID that occupational stress disproportionately affects healthcare workers, partly because of their excessive workload, emotionally charged environments, and demand nearly always outweighs capacity. The issue with occupational stress is that there are significant negative consequences, not just to the individual, but to the organization, and in a healthcare setting, to patients. It leads to performance decline in the clinician, increased patient safety incidents with medical errors or low quality service, and it also has increased costs to the organization. There are huge issues with staff retention and psychological ill health, as we've been hearing about linked with COVID, but COVID being one stress, occupational stress presents the same challenges for workers. Some of the data that has been published pre-COVID would suggest that clinicians working in psychiatry services may be exposed to more risk. Partly they have to manage their own stress level, they have to manage that of their teams, they have to treat stress and mental illness in their patients. As clinicians, they share the difficulties in help seeking, but perhaps more so on account of the stigma of seeking help when they work in that organization themselves. And then there are certain legal responsibilities. And of course, what we all remember is that our successes are often long forgotten, but it's our failures that follow or haunt us. Jason or Justin? As Tara was saying, the Irish healthcare system was already under-resourced and excess demand before COVID, and that's the same worldwide. The fact that people have to work longer in excess of the European Working Time Directives has led a lot of people to consider working abroad, and the issue of retention is a big problem with many vacant posts nationally. And of course, there is a sense within psychiatry of an increased prevalence of mental illness, and indeed within medicine. Look at rates of obesity or diabetes, where they're increasing all the time. And that is met with an increased patient expectation of accessing services. When we move on to the mental health services, they were already fragmented and poorly resourced. And the policy document, A Vision for Change, shows that the mental health budget has decreased since 2008, and recommendations of teams being staffed continue to be well below average. The consultant psychiatrist per 100,000 population is half of what it is in the European Union. And there has been a recent surge in referrals, particularly to child and adolescent mental health services. They have been up 26% since 2012. Next slide, Justin. So in 2018-19, we conducted a survey to look at the level of stress among consultants working in child and adolescent psychiatry. And we managed to get 46% of all consultants in Ireland. It was a survey monkey, and the main outcome measure was that of the Copenhagen Burnout Inventory. The clinicians were seasoned clinicians, and they were pulled from both CAMS, community outpatients, but also the inpatient services, including liaison work. Next slide, please. What we found was that the majority of consultants showed moderate or higher level of burnout. Now, the Copenhagen has 3 scales: work-related, personal burnout, and patient-related. And you can see that work and personal burnout were 72 to 75%. What was really reassuring to notice was patient-related burnout was much lower, 27%, suggesting at that time they hadn't yet gone into compassion fatigue. 70% had seriously considered changing job in the previous year, and nearly the same amount had said that they had reservations if they were to retrain again as a student, would they go into child psychiatry? So the occupational stress they're experiencing has huge impact on the specialty of child psychiatry. Looking at A Vision for Change recommendations, the majority of consultants were staffed at below a 50% recommendation. The majority also expressed low level of confidence in the government commitment to investment in child psychiatry, and low confidence in the HSC's effective planning of child psychiatry services. Those with higher burnout scores were more likely to have less confidence in either the HSE or the government. Next slide, please. We also had some open response questions like Tara had, and we did a thematic analysis, and we found three main concerns from our respondents. One was the concern that they had inadequate access to MDT, multidisciplinary skill set. The second was that they had inadequate access to resources and funding. We knew that anyway. But what was a surprise was 56% of mentions were about a negative public appraisal. Next slide, please. This created a vicious cycle for the respondents in that the public with negative, unrealistic, or misconceptions about what CAM's core business was led to increased referrals to the system, to the service, which were outside of their core business or outside of their remit, and for which they may not have had any capacity to make a difference to that family. The clinician either refused the referrals, they saw the referrals but were aware that they weren't able to provide adequate service to that family, given that they didn't have it, or they tried to provide the service, but that was at the expense of other referrals that had to wait even longer now because of the increased demand. This led to demoralization and stress within the consultant, but it also was associated with poorer quality of service. And you can see there from the negative feedback loops that this all led to referrer dissatisfaction with CAMS, increased patient and family dissatisfaction, and an increased inability of clinicians to feel that they were effectively delivering the services that they were meant to deliver. Next slide. One of the things they suggested was a public educational campaign would be something that was crucial to help define what the core business of CAMS was. Next slide, please. After this survey, we expanded it to include all multidisciplinary team members in CAMS, not just clinicians, but non-clinical services as well. And it was interesting that there was no difference. Some people were worried that clinicians, the frontline clinicians, experience more stress than the administrative staff or indeed catering staff. And in this study, we found no difference between the two groups. Just under 50% of respondents were experiencing moderate or higher levels of burnout, so slightly less than the consultant group. And all staff, fortunately, continued to retain positive patient links. Next slide, please. Alarmingly, we felt that 37% expressed that they felt burnt out at work, 43% were emotionally exhausted, and 30% said they were tired of working with patients. Next slide. In terms of the external factors, as before, there was significant low level of confidence in government commitment, of HSE's ability to effectively manage. Nearly half of them felt it was more stressful working with children and families than those that had previously perhaps worked with adult cohorts. 38% did not feel valued in their job, and 28% felt that their colleague may not have had good job satisfaction. And both of these issues, the workload and their job satisfaction, were perceived to interfere with their ability to develop new initiatives. Nearly half of the workforce had seriously considered changing jobs in the previous year, and 50% of those were unsure if they would remain within a CAM setting. Next slide, please. Controlling for other confounders that might influence stress, what we found was those clinicians that had higher effort to the reward they got from their job were more likely to be stressed, as were those that indicated they were overcommitted or were unwilling to consider working again in CAMS. We asked clinicians in this survey and respondents whether they had received any training and support within the organization to deal with occupational stress, and this was pre-COVID. 63% had no training in their professional experience. 86% had no on-the-job training when they arrived. And 66% felt their organization did not put anything into play to help reduce burnout. 29% of respondents felt they had no one that they could talk to within their organization about the level of stress they were experiencing. And this was correlated with the degree of burnout. Next slide. We conducted another survey in St. John of God's adult mental health services, and again with clinicians and non-clinicians. And what we found here was actually there was lower levels of burnout compared to either the consultant child psychiatrist or those working in the CAMHS clinic. As before, patient burnout was protected compared to personal or work burnout. Interestingly, in this study, 100% of medical staff felt valued, and it was less for non-medical or non-clinical staff. And that concept of presenteeism, where somebody attends work when perhaps they should have stayed at home, was present in 79%. And the worry about that is that that definitely is something, if continued, would lead to burnout. What we found in the adult mental health services was a concern in that the non-clinical staff, the admin staff or the support staff, were those that were experienced the highest level of burnout. They were those that were least likely to work again in mental health services. And they were those that felt a higher degree of overcommitment to their job. They also felt less valued than the medical staff. And the open-ended questions by way of what supports respondents would have liked, this was pre-COVID, was the old chestnut of increased staffing, reduced workload, increased access to allied healthcare professionals, and increased home support for patients post-discharge. Next slide, Justin. So we come back to the fact that we're now 12 months on working with COVID, and COVID has represented for all of us a continuous and chronic and unpredictable stressor. And it is most likely that any other trivial stresses that we would have had, or indeed significant stresses like a child being unwell, like a marriage breaking up, like financial distress, when added to the overall level of stress that COVID is providing, makes it very easy to see how even the most resilient amongst us, the stressors will reach above our resilience threshold. Next slide. We know in terms of research that has been done with acute emergencies, disasters, or pandemics, and Neil has spoken about this morning, that the mental health impact is far larger and lasts for far longer than the acute medical ones. And the issue for COVID is that there may be both direct and indirect effects. The virus attacking the nervous system, creating a new increase in neuropsychiatric presentations, but the collateral damage from restrictions imposed on us will create increased mental health difficulties on the community. And this will also be the case for service providers. Next slide, please. Going back to the three salient features, the exhaustion, the ineffectiveness, and the cynicism, I would add that there are additional psychological experiences and moods that clinicians have to deal with. That of guilt, anger, anxiety, and depression that we're feeling when we're feeling stressed and unable to do our job effectively. And sometimes relief when we decide to become cynical and actually just clock in and clock out. But the specific issues with COVID is that we know, looking at the CAMHS data, that after an initial drop in referrals to child psychiatry services or mental health services or ED services, that they have actually started to increase. And if we look at our referral rate in Lucena clinics in November, it was 180 times greater than the November of the previous year. So we are looking to increase referrals to our services. If we look at Maslach's control aspects, we have no control over this pandemic. We have control over small things, but we have no idea when it will end, when restrictions will stop, when the vaccines will arrive at our shores. If we look at the reward, whether it's real or perceived, There is a sense from some people, and we've heard it in the media, that they're looking for increased monetary recognition, increased time off, and sometimes it's just a sense that they are not being as valued as other people. If we look at the community that we're working in, it's completely different to the one we were before. I think Tara mentioned the fear of some staff that they would be deployed to other areas. That hasn't happened in mental health services, but our community has disbanded because most of it has become virtual. And so the same support network you would have gone from the face-to-face is not present. The other domain was that of fairness. There is a sense amongst individuals of injustice. Some feel that they have been more exposed to the virus than others, or to the risks of work overload than others. We also know that there's a sense that not everybody is adhering to the restrictions. Not everybody had equal access to PPE, or even on the vaccine list. There's still staff amongst our services and the frontline workers that have not yet received their vaccine, despite what is being stated in the media. So for those that are in that position, there is a real sense of injustice. And lastly, the values. There's a lack of sense that the public or the HSE are expressing or showing a commitment to mental health. There is no clear recognition at the moment that we are going to get the promised 10% of mental health supports to CAMHS that we had been alerted to. Next slide. So the stressors that we had found by the data that were collected pre-COVID have been multiplied. So, you know, it is absolutely to be expected that not only the frontline workers, but those working in community services, and indeed a little bit removed from the frontline, are going to be exposed to significant psychological distress. Justin, next slide, please. So this storm, pre-COVID, stress levels were already high in the mental health services. COVID has been a major stressor and is likely to cause increased psychological distress. Front care workers in mental health services are at risk by virtue of their own mental health difficulties in reacting to COVID, and also the increased demand on their mental health services. I think the last slide, Justin, please. So what can we do about it? Obviously, what we're doing is what Claire has organised today. Be aware of it. It's really, really important, and making sure that all our organisations are. The other thing is, as we are doing by way of the presentations we've heard, is that we are quantifying the level of stress, and we're looking at it from different groups because it's not all the same. So what we are doing in Crumlin and in other services is we're looking at occupational stress among clinicians working with children, and that's extended to the teacher population as well as a clinical population, and also extended to security and admin staff. We're also looking at a national survey looking at the stress levels among mental health providers, again, clinical and non-clinical. We're just beginning some very interesting qualitative work, which has been allowed possible by the Aoife Galvin AIB Newman Fellowship Award, and Dr. Shane O'Donnell is our Newman Fellow in UCD. And this is a 2-year mixed method study looking at front and second line clinicians working and trying to get a lived experience of the stress that they're experiencing, and then developing interventions based on that that would fit for an Irish healthcare service. In terms of interventions, it is helpful to look at past models that have been developed from other pandemics, but also to make bespoke ones for our own health services, to configure obviously services. Just throwing additional money and resources, which we know we need, needs to be done very carefully, because availability of funds will be much less post-COVID. So it is about being innovative about how we increase resourcing to services. The other thing is to optimize the work environments and to try and keep some of the positive things that we have already experienced through COVID, such as Zoom meetings, Zoom conferences, the lack of a need to travel as much as we have, and most importantly, being able to balance some of work with staying well and walking while you're taking some of those telephone calls. I'd like to thank our group in UCD. There are many, many more people that are involved in the research. And if I have time for 1 or 2 questions, I'd be delighted to take them. Thank you.
Thank you very much. that was a fantastic presentation, and thank you for sharing your insights into the research you've done with us. The child and adolescent mental health services, we know before COVID the incredible strain that service was under, and it is really interesting to see the adult mental health service also, and how that is being affected. I really like your take-home messages, and where we can go from here. There are some very strong signposting messages there in terms of evaluating our bespoke interventions and taking the positives from this as well. I see a lot of people are commenting on the value and expressing their gratitude for this presentation. So I would like to say that your presentation has proven to be very, very welcome and very much appreciated from the audience. I'm not seeing any other questions. Have any of the panelists any questions before we go for coffee? Are mental health staff more resistant to help seeking, or maybe more reticent in seeking help, Fiona?
There's a little bit of data on that, Claire, that they are. Now, obviously, clinicians and doctors are the very worst at help seeking, and they keep going until they reach this performance cliff, and then they fall down from it. And the sorts of coping strategies that they'd normally use, which is, friends and walking and health, they're the first thing that goes when you get stressed. Is you reorganize your day, but actually, sadly, what you do is you just make your day stretch to cover all of the work. So that's the typical practice of clinicians and doctors. Within mental health, there's a huge stigma in attending the services yourself. Now, I know that Ida Delargy and some other colleagues have set up some specific occupational help for psychiatry staff, because it is difficult to attend your psychiatrist, and in the past you'd be sitting in the waiting room with maybe some of your patients who are attending. So it did create that little bit of a difficulty. I think, working in mental health, we do learn a lot of the coping strategies, and the difficulty is applying it to yourself. Practice what you preach. And it engenders a lot of guilt and maybe anger at, why is it that I'm getting distressed or depressed when I know what I should be doing? Many of us who are parents of children, would feel that as well. If our kids have, mental health difficulties, we're saying, I should know how to treat anxiety here. Why is it that I'm not, a better parent? But I think that is just the reality. Mental health is very prevalent. We all experience mental health distress. There comes a time where we do need to be able to hand over to somebody else to help us manage it. And we're probably not great at doing that.
Comment from Sandra, you've hit the nail on the head, Fiona. Clinical staff keep going until they stop. It sounds like we need serious investment in healthcare at the front line just to be listened to. So I'm going to say thank you sincerely to our panelists this morning, to Professor Fiona Timmins for the welcome address, to our fantastic keynote, Neil Greenberg, to Ike, Tara and Fiona. What wonderful morning we've had, plenty of food for thought. And we unfortunately we've run into the coffee break. If it's okay, we're going to start back at 12:20.